good morning. My name is Angel Scanzera, and today we're going to be talking about therapeutic contact lenses in the management of ocular surface disease. I'd like to start with a question. Okay, so varied experiences. Most people have had some experience with soft lenses. We'll kind of go over everything today. There are various different types of contact lenses, soft being the most common lens. These are mostly used for refractive purposes, but they can also be used for cosmesis if we need a tinted lens for a patient with significant light sensitivity, and therapeutic reasons as well. Rigid gas permeable lenses really do provide the best optics for patients. It's a corneal lens that sits entirely on the cornea, but because there is tear film between the contact lens and the cornea, there is improved vision and optics. And these are usually used for patients for refractive correction, but they also help with corneal irregularity. And really the most beneficial patients are ones with corneal irregularity from keratoconus or post-grafts. A hybrid lens is similar to the RGP. It provides the optics of the RGP because it has the RGP center, but it has a soft skirt, so it has the comfort of the soft skirt as well. And then the last one is the Scleral lens, and this one has really gained more popularity over the last 10 years, even though it's been around for a long time. And it is becoming more common to use it for normal corneas, but it's most beneficial for patients with corneal irregularity to help with the optics as well, and therapeutically to help with ocular surface disease. So today our focus is going to be on soft and scleral lenses. So I understand everyone's experience with therapeutic contact lenses is different, and it really depends on what options are available to you. Today we're going to go over some indications for contact lenses, soft lens parameters and fit assessment, scleral lens overview and fit assessment, and a case review. And my overall goal is that by the end of this lecture, you'll have knowledge of when to consider a soft and scleral lens for the management of ocular surface disease. That said, I will not be focusing on how to fit the lenses. I know Dr. Gomeri will be lecturing on this in a few weeks, so I do recommend that you attend her lecture as well. So what are the uses for therapeutic contact lenses? Main ones: mechanical protection, help with protection from lid scarring, lag ophthalmos if someone has an incomplete lid closure. It helps from environmental factors such as dust and wind that can be really irritating to the patient with ocular surface disease. They also improve or help with corneal epithelial hydration, wound healing, and pain relief. And I keep the joint delivery in parentheses. There are new studies that are working on this, but we won't be speaking about that today. So when should we consider therapeutic lenses? Ocular surface disease is caused by conditions which affect the eyelid function, tear production, or integrity of the corneal epithelium. Most commonly, we use these for acute problems such as corneal abrasions and erosions, and chronically with patients who have exposure keratitis or severe dry eye. But they're also really helpful in a variety of different types of surface disease, including persistent epithelial defects, neurotrophic keratitis, trauma, pain patients, chronic management of chemical burns, all the way down to, we'll speak slightly about K-pros at the end of the lecture. And really the main point is when other treatments aren't sufficient, a soft lens and scleral lens should be considered. So most of these patients have already tried artificial tears and topical drops. Some have had amniotic membranes trialed or tarsorrhaphies, and this might be the last option. In our practice, we start with a soft contact lens. If the soft contact lens isn't sufficient, we might then consider a scleral lens. So when it comes to the contact lens parameters, the first thing I want to talk about is the polymer of the lens. Hydrogel lenses are an older material. These lenses tended to cause hypoxia, corneal neovascularization, and edema. And the more popular polymer today is the silicone hydrogel lens, or SiHy lens. In the US, about 76% of soft contact lens wearers are in a SiHy lens. Internationally, that's at 65%, with the highest being in Switzerland at 91% and in Taiwan at 18%. The oxygen permeability is the reason the silicone hydrogel is so much better than that hydrogel option. It's actually a much higher oxygen permeability, which is the ability of the lens to allow oxygen through to the cornea. And then the oxygen transmissibility is the permeability based on the thickness of the lens. And so a +3 lens and a -3 lens will have the same permeability, but the transmissibility will be different based on the thickness of each lens. The Holton and Merz criteria was published in 1984 and determined that a oxygen transmissibility of 87 was the magic number for preventing corneal edema in overnight wear. And more recently, there are recommendations to revise that to 125. What I'd like to say is for our patients, I don't put any normal patients or non-ocular surface disease patients in overnight wear. I may fit them in a lens that is approved for that, but I do recommend it just to lower the risk of infection in those patients. Power is another parameter. Base curve is the measure of the curvature of the lens. As that number increases, the lens is flatter. And then the diameter of the lens and daily versus extended wear. So daily means that the patient is wearing the lens during the day and disinfecting overnight versus extended wear is wearing it full time. So here are some of the common contact lens materials that are used in the US. As you can tell at the bottom end, 8.4 is the DK for the soft lens, up to 28 for the AccuView One Day Moist. Those are all hydrogel lenses, so very low oxygen permeability. More recently, actually in the last 10 years, there have become more daily disposable hydrogel lenses available, which has really been a game changer for our dry eye patients. I think in the US, about almost 25% of patients are in Sci-High daily disposables compared to 37 internationally. Then if you look up all the way up to Air Optics Night and Day, that oxygen permeability is continuing to increase in those silicone hydrogel wearers. The FDA, or Food and Drug Administration, does approve these lenses for a specific replacement period. And extended wear, you'll notice even with the Biofinity, they recommend 6 nights and 7 days on, with the lens being good for a week rather than a month. So the Food and Drug Administration has to approve a contact lens to be used as a therapeutic. So we can use these lenses in the normal patient, but the definition for FDA approval was use as a bandage to protect the cornea and to relieve corneal pain in the treatment of acute or chronic ocular pathologies, such as bullous keratopathy, corneal erosions, entropion, corneal edema, and corneal dystrophies, as well as post-surgical conditions. So again, like I mentioned, if you look at that oxygen permeability, it's really high. These lenses are all available in 2 different base curves. And so we usually will start with one. If the fit isn't good, we might change the base curve to improve the fit. These lenses are also dependent or approved for specific wear schedule. So the AccuView Oasis as a daily wear lens is approved for 2 weeks, but if it's extended wear, it's 7 days. And I will say it's very important to note that if I'm using this on a compromised cornea, the patient should always be on a topical prophylactic antibiotic. So when we're assessing the contact lens, we're looking at the centration of the lens. We want to make sure that there's full limbal coverage. There's no exposure. We do want movement of the lens. However, we want to make sure that when there is movement, when the patient blinks, that there is no limbal exposure during that time as well. I think one of the most important factors is patient comfort. I will ask the patient if they notice dryness, and if they do, how long after they put in the lenses do they notice it? Does it get better when they remove the lenses? That information gives us an idea of if we should just change the base curve or if we should change the material altogether. Deposit formation, there are some lenses that may cause deposits for patients. Sometimes I'll switch straight to another brand. In other cases, I may just shorten that extended wear period as well. And then for every patient, I do avert the upper lids and monitor for papillae. So soft contact lenses have many advantages. They're fairly easy to fit. They're readily available. I would recommend having these in office at all times in case you do have a patient that needs a therapeutic lens. They provide great initial comfort and they can help with improving pain in patients with foreign body sensation. They provide full corneal coverage, and they're available for part-time or short-term full-time wear, and they're fairly inexpensive. Disadvantages, there's always risk of infection with contact lens wearers, and so a need for prophylactic antibiotic is really important in these patients. There can be severe lens loss in severe dry eye patients. And it may not be the perfect fit for some patients who have corneal changes due to injury or chemical burn. So which of the below is not a contraindication for contact lens use? Okay, that's pretty good. So with neurotrophic keratitis, these patients do need to be followed very closely. Because they don't have sensitivity, they won't be able to come tell you when they're in severe pain. Some of them might have blurred vision from epithelial defects and other findings. And so our most noted sign is redness, and those patients should be followed very closely and monitored for that. Active infection, we never want to put a contact lens on a patient with active infection. Poor medication compliance and hygiene are also things to consider. There we go. Okay. So for active infection, like we already talked about, we don't want to put a contact lens on any patients with active infection. Poor compliance, poor access to follow-up care would be a contraindication. Patients with corneal abrasions are really great for using contact lenses, except for those who are already contact lens wearers. We do not want to use that in patients with corneal abrasions who've had contact lens wear. Active cicatricial and Stevens-Johnson syndrome, the question mark is really there because it's all dependent on the severity of the surface of the eye. They might have an irregular ocular surface, and so it's, you might experience more lens loss, and that's really a questionable one. Other considerations include how long the intent to treat is, if there are any other options, and can they wear the lens during the day and use the other options overnight. So in our case, with patients who have ocular surface disease, we tend to put them in a daily disposable lens during the day. They'll remove the lens at night, and we'll use other options such as ointments, lid taping, or moisture chamber goggles. Okay, so now let's switch over to scleral lenses. A little bit of history. The scleral lens was conceptualized by Leonardo da Vinci in the 16th century. These lenses were manufactured in Europe by Frederick and Albert Muller, and the first lens was a blown glass scleral shell. It was to treat exposure keratitis in a patient with lid damage. In 1901, Zeiss created the first diagnostic fitting set. So these lenses were originally used in patients with ocular surface disease and later used for refractive reasons. Now fast forward to 2017, the SCOPE study group found that in a survey of contact lens fitters, scleral lenses were the most often prescribed for corneal irregularity, followed by ocular surface disease and uncomplicated refractive error. We did a retrospective review in our practice, and I'll say that actually in our practice, about 75% of patients are prescribed scleral lenses for ocular surface disease. And we do see a lot of surface disease, but we also believe that if we can get a great fit with rigid lenses in corneal irregularity, we will do that and use the scleral lens more as a last resort. So the lens type and fit is really based on the size of the lens. Again, if I have to put a patient with corneal irregularity into a scleral lens, I might start with a smaller scleral lens unless I can't vault entirely over the cornea. With a patient who has ocular surface disease, I try to go with a larger contact lens, and the reason for that is we can protect the cornea and the conjunctiva. Some of the limitations are small eyelid apertures or some blepharon formation that might not let us go as big as we'd like to with the lens. These lenses are available, they're gas permeable lenses in high or hyper decay, so we want an oxygen permeability of at a minimum 100, but if we can get over 140, that's even better. And some things that affect the transmissibility of oxygen to the lens is the tear film. So you'll see in the image on the right that there is that liquid reservoir that is filled with preservative-free saline solution, and it's vaulting entirely over the cornea and there's no touch. The smaller that area, the more oxygen is able to get to the cornea. And we also, we have the posterior haptics that are fitting onto the sclera. Those are supposed to be aligned, but in order to have some tear exchange, we might want one area to be a little bit flatter to allow for that. So what's the goal of the scleral lens? Protection from mechanical forces, such as the eyelid on blink or eye movements, maintaining a stable tear film on the ocular surface, which increases oxygen supply to the cornea, decreasing light scatter in irregular corneas to help with improving vision and to eliminate pain. So the first FDA-approved scleral device was the prosthetic replacement of the ocular surface ecosystem, or PROS lens. This is based out of Boston Foundation for Sight in Needham, Massachusetts. It was indicated for dry eye, limbal stem cell deficiency, disorders of the skin, neurotrophic keratitis, and corneal exposure. And this is a really great lens because it is highly customizable. You can make changes in 8 quadrants. However, it's not available everywhere. It's only available in 12 institutions within the US, and I believe a few places within India and Japan. And so Boston Foundation for Sight did create a new lens, I believe last year, called the Boston Sight Scleral lens. It's available between 18 and 19.5 millimeters, and it is highly customizable. The lens set is actually based on scleral anatomy, so there's a separate fit for the right and left eye. And then more recently, late last year, the Boston Exo material was approved for therapeutic use in scleral lenses, and most manufacturers use the Boston Exo material, so that really has changed the name of the game for ocular surface disease patients' availability to these lenses. So some advantages are these lenses are very customizable. We can really make as many changes as we need to with these lenses. They provide mechanical protection and full corneal coverage, and there's constant lubrication on the cornea, which helps with our severe dry eye patients and in healing. The disadvantage is the cost is high and much higher than soft lenses. The length of fitting is a bit lengthy in order to make it a good fit. However, once these lenses are fit, it usually is good for about a year. And the lenses do provide or cause some midday fogging. And so you'll see on the right, there's some fogging, there's some debris in the tear film. Previously, patients had to remove the lens, and I still do have a lot of patients that have to remove the lens in the middle of the day and clean the lens before reinserting it. More recently, there are some different coatings, such as the tangible hydropack, that do help with that midday fogging. So I'm not going to go over how to fit a lens. I think Dr. Glamari is going to do a good job of that in a few weeks. But I think it is important to know whether or not you are the person fitting the lens, what a good or bad fit is. And so if you look at the right picture, we're looking for central corneal clearance. That first area between the 2 green lines is the thickness of the scleral lens, followed by that green section, which is the corneal vault. And it's about 300 microns of clearance there. We also want to make sure that that clearance continues into the limbal area so that there isn't any touch. We want scleral alignment. One of the big things to avoid, especially in our persistent epithelial defect patients and neurotrophic patients, is bubbles. So you might have to work with their friends and family to help with that as well. This is a really good resource from Ferris State University that provides some pictures to be able to compare what you're seeing to these images. So in the top, it discusses central vaulting. In the middle, there's some limbal vaulting. And then in the bottom, you can see the edge relationship. So in that bottom left picture, there's severe edge lift. Patients will complain about this. They'll say they feel the lens, and they can usually pinpoint exactly where that discomfort is coming from. As we go further and further to the right, there is more and more impingement on the edge. So you'll see that whitening or blanching of the blood vessels. With my patients, we try to have them back during the fitting period after 1 hour, 3 hours, and 6 hours of wear. And during that time, the lens continues to settle, so it gives us more and more information. Before I remove the lens, I'll put in a drop of fluorescein and watch to see if there is fluorescein exchange under the lens. And then when I remove the lens, I'll immediately look back and check if there is any impression ring along the conjunctiva as well as fluorescein staining. And then again, like I said before, patient information is really useful. You can ask the patient if they notice discomfort, when is it? Is it difficult to remove? Is there pain upon removal of the lens? There are a lot of different factors that we can gain information from just from speaking to the patient about it. So this is just an example of a poorly fit lens. It's a little bit tight, and so we'd want to align that edge a little bit better. Now we're going to switch over to some cases. Some of them are graphic, so I do apologize for that, but let's get started with a question. Okay, so I might have to go over this one a little bit more. So we'll start from the top. Every patient who comes in with a corneal abrasion should be put on a prophylactic topical antibiotic to prevent any secondary infection. With patients who have abrasions from fungal or vegetative matter, we do not want to use a bandage contact lens. And the other contraindication is patients who are already contact lens wearers. So that would actually be D would be the answer for this one. Topical NSAIDs, I tend not to use these, but with non-steroidals, if a patient is in severe pain, I might consider it just to help with improving that pain sensation. And cycloplegic agents, when we think about a patient being hit in the eye, it can also cause an anterior chamber reaction. So if they're complaining of severe light sensitivity, I might consider it. But again, it's not always used and really used in case by case scenario. So going on to our first case, this is a 50-year-old white male that presents with a sudden onset of pain and light sensitivity. He has a history of being hit in the eye with a book 2 hours prior and is unable to open the right eye. After we instilled proparacaine in, he was able to read the 20/30 line without correction. And as you can see from this picture, there is a pretty large superficial epithelial defect. So in this patient who's complaining of severe light sensitivity, I did dilate to make sure that the retina was intact. So we did use tropicamide at that point. And at the same time, I did instill 1 drop of cyclopentolate. And then I put on a night and day lens for the patient, which is a 30-day extended wear therapeutic lens. And we sent the patient home with the lens and with a topical antibiotic. In this case, we used ofloxacin 4 times a day. The patient returned the next day and the epithelial defect was almost resolved and there was still some corneal haze. And so the patient was instructed to continue with the contact lens and continue with the topical antibiotics until follow-up. So I'll be seeing him tomorrow to remove that bandaged contact lens. This is a 67-year-old African-American male. He has a history of thyroid eye disease. He had orbital decompression done twice, in both eyes, most recently about a year prior to seeing me. And his main complaint is foreign body sensation and eye pain in the left eye. So just a brief history, this patient actually presented to the cornea surface with a persistent epithelial defect in the left eye. From trichiasis likely. So the patient was treated with a topical antibiotic and a soft contact lens, and the epithelial defect was almost entirely healed when he did see me. So the cornea specialist thought that at this point, as a long-term treatment option, a scleral lens might be a really good option for the patient. I fit the patient into a 17mm commercially available scleral lens. He was instructed on the application and removal and went home with the lens a week later. However, within a few days, the patient returned stating that he was just a little too nervous using the scleral lens at home. And so we did return to the bandage soft contact lens. Currently, he is in a night and day lens as well, and it is replaced every 3 to 4 weeks in office. We have tried instructing the patient on application and removal, and he just hasn't been able to yet. And so other options are maybe getting a family member involved in the future. So like I said before, I don't like keeping these patients in soft lenses overnight for so long because they continue to have to be on a prophylactic antibiotic as well. And so in the long term, I would like to switch them to a daily disposable silicone hydrogel lens during the day and maybe moisture chamber goggles at night. But at this time, we are replacing the lens in office every 3 to 4 weeks and epilating a few eyelashes every couple of visits. This is another exposure case. This is a 53-year-old female with a new complaint of painless left upper lid growth for 3 months. She presented to the oculoplastic specialist and was diagnosed with an adenoid cystic carcinoma. The patient underwent lacrimal gland resection and presented to us complaining of severe dryness, eye pain, and light sensitivity. You can see in that right picture, she has some pretty significant punctate epithelial erosions. So this patient was switched into a scleral contact lens. She underwent biweekly radiation therapy for 8 weeks and was later treated with a scleral lens during the daytime and ointment and moisture chamber goggles at night. The symptoms improved, the corneal staining resolved. I'll just compare those pictures again with the scleral contact lens. Question 4, what lens option should be considered for this patient? Okay, so this is another one that we kind of can review. In the long run, I think a large diameter scleral lens is a really good option. So remember, this is a rigid lens. And so with this area of inflammation, it might be really tough to fit the lens. However, there are some options that can be used. The eye print does a molding of the front surface of the eye to fit as a scleral lens. In this patient, this was actually a fireworks injury 3 days prior to being seen in our office. And so we recommended the patient continue to be seen by his cornea specialist. He underwent amniotic membrane transplants and was on anti-inflammatories for a long period of time. In the long run, this patient might be a really good candidate for scleral lenses. However, soft lenses in this patient would likely cause frequent lens loss. And currently with that edge of the scleral lens on this conjunctiva, it would be really tough to fit this patient. On the contrary, these are patients with Stevens-Johnson syndrome and toxic epidermal necrolysis. So SJS and 10 are inflammatory reactions secondary to drug reactions and infections. They affect the skin and mucous membranes and can cause blisters, erosions, and unfortunately mortality, a high mortality rate in these patients. So a study by Yip found that 50% of patients with 10 develop late ocular complications. These include severe dry eye, trichiasis, symblepharon formation, dystichiasis, and visual loss, and, to name a few. With this patient, if you look at the right, you might think that this is just a poorly fit lens, but this is actually just a very angry eye. This patient presented about 3 weeks post presentation of SJS. And so in these patients, we actually do want to fit them a little bit earlier in the process to help with preventing conjunctival keratinization, as well as symblepharon formation. So this is a 41-year-old white male with a history of chemical burn in the right eye. This was him on presentation. He had a history of hydrofluoric acid injury in the right eye in 2005, and within 2 days had a large partial thickness skin graft used from his thigh, which healed very well. So in 2015, he came to see us presenting with a complaint of constant dryness and epiphora. Other findings included 20/40 vision, 60% corneal thinning, and Delin formation. And the patient was already on treatment with preservative-free artificial tears, 4 times a day, UV blocking sunglasses, erythromycin ointment each night, and a moisture chamber at night as well. So we fit this patient in a 15 millimeter commercially available scleral lens. This was a patient who had immediate symptom relief and wanted to go home with the trial lens the same day. He ultimately was fit with this lens and used the lens during the daytime with the moisture chamber goggles at night. The epiphora improved immediately, and his corneal punctate epithelial erosions and Delin resolved fairly quickly as well. So the patient's vision improved from 2040 to 2020. And actually, I do want to point out, this patient thankfully had a really good Bell's reflex, and so that did help with some of the dryness prior to presentation with us. So I know Dr. Cortina spoke about K-pros last week. I'm briefly going to talk about the contact lenses in them. So indications for K-pro include graft failure, aniridia, chemical burn, ocular trauma, herpetic keratitis, and mild forms of autoimmune disease. Some complications from the K-pro include compromised ocular surface due to limbal stem cell deficiency, keratoconjunctivitis, neurotrophic keratitis, and exposure keratopathy. And so these patients tend to need a contact lens to prevent evaporative drying and help with surface inflammation. And so immediately following the surgery, the patient is put in a standard lens. It's a contour lens, which what we talked about is the oxygen permeability is 18.8. In these. However, we're not worried about corneal swelling in these patients. And so these lenses are actually selected based on thickness and durability, as well as the availability of the parameters. So they're usually started with a 9.8 base curve, plano power, and 16 millimeter diameter lens. And the base curve ranges from 6.8 to 9.8, and the diameters are available in 12 millimeters to 24 millimeters. And so it is a really good lens to use with a lot of different options for us. Considerations for the contact lens fit include centration and full coverage. And at UIC, about 30% of patients continue with the fit in the first contact lens that they're given after surgery. A lot of them are sent for refractive concerns, but also poor lens fit, frequent lens loss or deposits, glare and photophobia are common as well. And then one consideration is making sure to have full coverage of the tube shunt and not to have any rubbing along that area. So a long-term bandaged contact lens is the standard of care in these patients. The contour lens is replaced every 6 to 12 months. In these patients, I believe it's usually every 6 months. Once they're seen by the contact lens service, it's usually due to a history of some complications. And so these lenses might be replaced more frequently depending on the patient. The goal of the contact lens is to maintain hydration and protect the corneal tissue surrounding the anterior plate. And there are risks of lens loss and lens deposits. With lens deposits, we may end up changing the patient to a hybrid lens because that rigid area will not cause deposits. So as long as we can center the lens well, the patient can have good optics and the deposits will only occur on the peripheral parts of the lens. So this was a patient seen in our clinic. It was a 61-year-old white female with K-Pro. She had a history of presumed keratoconus and multiple filled grafts in both eyes, and she was status post K-Pro in the right eye. So she was followed for a long period of time in our clinic, and at some point ended up having a tube erosion and required a tube revision and scleral patch graft. So in these patients, one thing I didn't mention earlier is with the hydrogel lenses, they do stain with fluorescein. So in these patients, I would remove the hydrogel lens and then stain with the surface with fluorescein to check for any epithelial defects and look at, especially at the tube in these patients. When it comes to the contact lens, we either want a lens that is large enough to fit entirely over the tube so that there's no rubbing of the edge of the lens on the tube, or one small enough, if we can center it, that misses the entire tube. And other things that we would consider are if there's lens fluting, that means that the lens might be too flat. If the lens isn't moving or they're noticing an impression or blanching on the conjunctiva that might be too tight, we'd have to flatten that lens. So ocular graft versus host disease is typically caused in patients who have had a history of leukemia or lymphoma and underwent allogeneic stem bone marrow transplants. And these patients are treated with anti-inflammatories and artificial tears and autologous serum drops. They have a pretty high regimen, and unfortunately, if you speak to these patients, they'll be using preservative-free artificial tears sometimes every 10 minutes. So the goal is to help with decreasing that to help improve their quality of life. And contact lenses are one of those options. And so the first case series is of 7 ocular graft versus host disease patients with moderate to severe dry eye fit with the night and day lens. They wore the lens nightly for a continuous wear basis for 7 nights. And they noted improved subjective symptoms and vision. There was no change in fluorescein staining or tear breakup time. And the second case series was a phase 2 clinical trial examining the safety and efficacy of contact lenses for ocular graft versus host disease. This included 19 symptomatic patients. They used the Pure Vision lens and a prophylactic topical antibiotic, and the lens was replaced every 2 to 4 weeks. The patients noticed an improved OSDI within 2 weeks, which remained stable for 3 months. And some adverse events included foreign body sensation, swollen eyelids, and excessive tearing. So again, in these patients, these studies are a little bit older, from 2007, 2015, but there are a lot of daily disposable silicone hydrogel lenses available. And so in our clinic, we usually start with a daily disposable silicone hydrogel lens, and we'll consider a scleral lens if there is no improvement in symptoms or signs. So here's an example of a patient with ocular graft versus host disease and filamentary keratitis. This is a 55-year-old male with a history of multiple myeloma, post-stem cell transplant 5 years prior. He complained of dryness, foreign body sensation greater in the left eye than the right eye, intermittent pain, and light sensitivity, and had a baseline OSDI of 25. Slit lamp findings show lid telangiectasia, punctate epithelial erosions, and conjunctival staining and filaments in each eye. So you can see along the edge of the cornea a significant amount of filaments in each eye. The patient was already using preservative-free artificial tears, erythromycin ointment, and warm compresses twice daily, and he was already fit with the bandaged contact lens. He was switched over to a daily disposable SiHy lens, and his OSDI improved from 25 to 9, and slit lamp findings as you can see, the filaments resolved and the punctate epithelial erosions resolved as well. So for my last question, this is a 46-year-old white male with a history of severe ocular graft versus host disease who presented with a non-healing epithelial defect. What treatments might you consider? All right, good. So really, these patients might be on several different treatments that work together to help with the surface of the eye. A bandage soft lens might be trialed first, and if that doesn't work, we switch to a scleral lens. In these patients, they have a compromised cornea. We'll put a preservative-free antibiotic drop into the tear reservoir of the lens prior to insertion, and then fill the rest of the lens with a preservative-free saline solution before insertion. And these patients do need to be followed very closely. So this might be one of the cases where I would potentially have the patient wear the lens overnight. But in the long run, if a patient needs to be in a scleral lens overnight, then there is an option of having them wear one during the day while the other is being disinfected. And then at the 12-hour mark, change to a new scleral lens while the second lens is being disinfected as well. And it's important to note, especially in ocular graft versus host disease patients, that these patients are immune compromised, so it's really important to monitor them closely. This is our last patient. This is a patient with neurotrophic keratitis. It's an 18-year-old white male with a history of familial dysautonomia. Familial dysautonomia, also known as HDN, is a genetic disorder that affects the autonomic and sensory nervous system. So these patients end up with decreased corneal sensitivity. And so this patient came in complaining of frequent corneal abrasions and blurred vision in both eyes. Best corrected visual acuity was 2400 in the right eye and counting fingers in the left eye. And initial ocular findings included severe punctate epithelial erosions in both eyes and essential epithelial defect in both eyes as well. So primary treatment for these patients includes punctal occlusion, lubrication, ointments, protective goggles, and soft contact lenses. And if those options don't work, we might switch to some of the secondary treatments, including scleral lenses, but also tarsorrhaphy, autologous serum tears, and amniotic membrane transplants. So this patient was fit with a 16.5 millimeter scleral lens in both eyes. We helped the family member train in application and removal of the lenses. With familial dysautonomia, these patients have varying level of severity. So some might be able to do it on their own, but some might need help from caretakers or family members. His vision improved in the right eye from 2400 to 2050, and in the left eye from counting fingers to 2200, and the epithelial defects resolved and the corneal staining resolved as well. So I just wanted to go over a few resources that are available to you. GPLI has some really great information. Every third Tuesday of the month, they have live webinars, and they can lecture on almost anything when it comes to custom contact lenses. So they'll discuss scleral and soft lens updates. They'll also discuss post-surgical care, and it is free to join. So I would highly recommend getting involved and listening to some of those webinars. They have some really great lectures. The Scleral Lens Education Society also does have a lot of great resources. They work closely with GPLI. You do have to sign up for their site, but they do have some resources that are really beneficial for you. And then if you're interested in fitting scleral lenses for normal corneas or ocular surface disease, I would highly recommend the new book that came out last year, Contemporary Scleral Lenses. Lynette Johnson and Melissa Barnett did a really great job, along with a lot of other authors, to help discuss different case scenarios and how to fit the lens. It's about 500 pages of great information. So I'd like to thank my colleagues in the Contact Lens Service, Ellen Shorter, Charlotte Johnson, and Tim McMahon for helping provide me with some of these cases that we use today as well. And I'd also like to thank Jonathan Scullard and Lauren Sicca from CyberSite for their help in planning and organizing these lectures. I think I'll take questions now. So the first question, which kind of contact lens is the best choice for the patient? I think that's really difficult to say. It's really dependent on what option is available to you. But I would, like I said, I mentioned some of these therapeutic contact lenses. Things you want to look for are a high oxygen permeability. That's really one of the most important factors for these patients to help in preventing corneal edema. Can you use a soft contact lens for bullous keratopathy? Yes, you can. I would still use some ointments at night as well. And Can the scleral lens be used for drug delivery? So we didn't talk about drug delivery today, but with acanthamoeba, with any infection, I would likely recommend against any type of contact lens wear, especially because the highest risk factor for these cases of acanthamoeba are contact lens wear. So what is better for corneal abrasion, observation and antibiotic ointment or a bandaged contact lens? I think this is really dependent on how severe the abrasion is. I don't use a contact lens every time. I would say most frequently I send the patient home on artificial tears and prophylactic antibiotic, some ointments at night, depending on the severity of the patient's symptoms and how large that abrasion is. So I'll consider a bandaged lens if the patient's complaining of severe, 9 or 10 out of 10 pain, or if they have more light sensitivity, anything along those lines I might consider. And if it's a really large defect, then I might do so as well. I just lost it. What is better for, I think I just saw one, but it was what is better for lack of ophthalmo, surgical treatment or contact lens? In our practice, I think our physicians are very conservative. If we can help it with the contact lens, we'll always trial that. It's also patient dependent. So I think it's a balance of both. And that really, I would say the most important thing is having good co-management with your oculoplastic surgeon. Do I know of any randomized blind study of soft lens material safety and tolerability? I'm not sure if there was a randomized study comparing all of them. There are several studies comparing the benefit of high decaying material and tolerability. Sorry, I'm not sure I can see anymore. So, hi, Dr. Lyons. When it comes to the ProCara lens, I don't use it here. Usually the cornea specialist will do it, so we do leave that decision up to the cornea specialists. And by the time they come see us, they likely already tried it or decided that the scleral lens is a better option. Age limit for scleral contact lenses, I tend to see more adults here, but scleral lenses you can definitely use them in patients that are children. The main thing with that is really making the patient comfortable and gaining that comfort with the patient really early on in the process of meeting them with them and their parent. And so you might have to have the parent involved in insertion or removal of the lens. But like I said, again, if you have a large contact lens coming to the eye, you want to make sure not to intimidate the patient. That said, they still are really good treatment options for some people. So patient with a recurrent corneal erosion, which one do you advise? Bandaged contact lens or sclerals as a mode of treatment? Again, I always start with the soft contact lens. And with corneal erosions, the soft contact lens does need to be used for a longer period of time. And so the patient will be on a prophylactic antibiotic and followed for 3 to 4 weeks. Sometimes we do keep that, we replace the lens, but we'll keep it going for 2 to 3 months if needed in order for that recurrent corneal erosion and pain to heal. Can we use ordinary scleral lenses for drug delivery compared to the PROS lens? Yeah, so like I mentioned, the Boston XO material as well as the Boston Sight scleral lenses are FDA approved for therapeutic use. When it comes to drug delivery, I don't have much experience with the research on that, but I think the PROS lens is a really good option as a last resort for patients who can't be fit in anything else. And so severe conjunctival inflammation or pinguecula, if we can't get that with a scleral lens, we might consider some other options. What is your choice of lubricant with the bandaged contact lens? The main thing I would say is preservative-free artificial tear is really important, so that the preservative is not bothering the eye for such a long period of time, especially with bandaged lenses that aren't removed on a daily basis. You always have to prescribe a bandaged lens after removal of a corneal foreign body. I think that's really dependent on the size of the corneal foreign body and the discomfort of the patient and in the healing process. Patient with SGS and corneal ulcer, would you advise on a bandaged contact lens? If it is a patient with a sterile ulcer, I might consider a scleral lens. If not, then I would likely try to treat have the cornea specialist treat the corneal ulcer first before considering the scleral lens. And I want to make sure that there is no active infection for those patients. Okay, any other questions? Thanks again for attending this lecture with me this morning, and thanks again to CyberSight for hosting.